Okay, think about those moments, when you're just absent-mindedly picking at a hangnail. Or maybe smoothing a rough bit of skin.
Yeah, pretty common, right.
Totally. But imagine if that urge was just way stronger. Like a constant need that ends up causing real damage, real distress.
Exactly. That's kind of the area we're getting into today.
Right.
This deep dive is all about excoriation disorder. You might also know it as dermatillomania or skin picking disorder.
Okay.
We're really going to unpack what this condition is, look at the research, what might cause it, the impact it
And
has,
how people can deal with it.
and the different ways it can be addressed,
Yeah.
based on medical and psychological research.
Good stuff. We've looked through quite a bit of that research, the medical literature.
Hmm.
And the goal here is really just to give you a clear, a comprehensive picture of excoriation disorder, something that goes beyond the sort of common misconceptions.
Yeah, moving past the basics.
So let's start right there. What exactly defines this as a disorder rather than just, a habit?
Well, the absolute core feature is this repeated, powerful urge or impulse to pick at your own skin.
Okay.
But what makes it a disorder, what elevates it, is that the picking causes significant psychological distress, intense guilt, shame, anxiety, and often actual physical harm,
Yeah.
tissue damage, infections, things like that.
Got it. And clinically, how is it seen?
That's important too. Since May 2013, it's been officially recognized in the DSM-5. It's classified as a mental disorder, specifically on the obsessive-compulsive spectrum.
Obsessive compulsive.
Yeah, and it has an ICD-10 code too, L98.1. It's actually not classified as an impulse control disorder anymore.
Oh, interesting. So that shows a change in understanding.
Exactly, a shift in thinking about what's really driving it.
What about dermatillomania? That's a word I feel like I've heard more often.
You probably have, yeah. It's still widely used, and it basically means the same thing.
Okay.
But excoriation disorder is definitely becoming the preferred term, especially in clinical settings and research. It's more precise. Though you might still hear other names too, like skinning disorder, neurotic excoriation, acne excori,
Wow, lots of terms.
pathologic skin picking, compulsive skin picking, psychogenic excoriation. They all point to the same underlying issue.
Okay, so definitely not just fidgeting. What's it actually feel like for someone going through this regularly?
People often describe specific feelings building up before they pick or while they're doing it.
Like what?
Like a growing tension, maybe
No.
anxiety, or just this general feeling of unease or stress.
Mm.
And then, interestingly, sometimes after picking, they might feel quite depressed or down.
Really? Even though there might be relief during...
Well, the driving force is this really strong compulsive urge, right? To pick or squeeze or scratch at what they perceive as a skin defect.
A perceived defect, so maybe something tiny or unnoticeable to others.
Exactly that. It's about their own perception. And yes, during the picking itself, many do report a sense of relief, maybe even satisfaction. But here's something really interesting. The level of awareness can vary hugely. Some people are fully aware they're doing it, they hate it, they want to stop, but they just feel powerless.
Okay.
Others can almost enter this kind of trance-like state. They might not even realize they've been picking until afterwards, when they see the damage.
Wow, like dissociated.
Sort of, yeah. And it's not fixed. The same person can experience both states at different times. It really shows how complex it is.
That really gives you a sense of the internal struggle. Where does this picking usually happen on the body?
The face is by far the most common location, significantly so.
Okay.
But really, it can happen anywhere. Arms, legs, back, gums even.
Gums, really?
Yeah. Neck, shoulders, scalp, stomach, chest, even fingernails, cuticles, toenails. Pretty much anywhere someone can reach.
Right.
What's interesting, though, is most people tend to have a primary spot they focus on.
Their main target area.
Exactly. But they might also pick at other spots, sometimes maybe to let the main area heal a bit before going back to it.
So it's almost like managing the damage to keep the behavior going.
In a way, yeah. It's complex, and the way people pick varies too.
How do you mean?
Some might have lots of really short picking episodes throughout the day, like a quick impulsive thing.
Okay.
Others might get into these really long sessions, sometimes lasting for hours at a time.
Hours. Wow.
Yeah, and while most people use their fingers, it's important to note that a significant minority, maybe 20–30% in some studies, actually use tools.
Tools, like what?
Tweezers are common, sometimes needles.
Needles. Ouch. That sounds like it could cause way more damage.
It absolutely can, yeah. Increases the risk quite a bit.
So what usually triggers these episodes? What sets it off?
Often, it's a response to specific triggers. One really common one is just the physical sensation of the skin.
Like feeling something.
Exactly. Feeling a bump, a rough spot, maybe a stab, or even just being more aware of their skin can start the urge.
Okay.
But strong negative emotions are huge triggers too. Anxiety is a big one, especially anxiety that might be linked to underlying obsessive compulsive patterns or tendencies.
Even if they don't have a full OCD diagnosis.
Precisely. That anxiety might be there, sometimes quite severe, sometimes milder, and maybe it's never even been formally diagnosed. But it can definitely fuel the picking.
We've kind of touched on it, but let's talk more directly about the physical harm. What are the typical consequences, the complications?
Yeah, they can be really significant, unfortunately. Infection is very common right at the picking sites.
Yes, Senate.
And just general tissue damage. In more severe situations, there's a real danger of sepsis.
Sepsis, that's life-threatening.
It can be, absolutely. And sometimes the damage is so bad that skin grafting is needed to repair the area.
Wow.
You can also get things like epidermal abscesses. Those are collections of pus under the skin.
Okay.
And the research literature has some really quite alarming examples of how bad it can get.
Like what?
Well, there was a case report of a man who picked down literally to the muscle tissue on his foot.
Oh my.
Another of a woman who picked a hole through the bridge of her nose, needing surgery. And even one case where someone picked so deeply on their neck, they actually exposed their carotid artery.
That's terrifying. These are extreme, hopefully.
They are extreme cases, thankfully, but they really illustrate the potential severity of the self-inflicted physical harm.
It's hard to fathom the distress driving that.
It really is, and beyond those immediate dangers, there can be chronic issues too, like persistent neck or back pain.
From the posture.
Yeah, exactly, from being hunched over picking for long periods. And of course, severe physical scarring and disfigurement are very real possibilities, which can have a huge long-term impact on self-image and confidence.
And the emotional toll must be immense, too.
Absolutely devastating. It's not just physical. Excoriation disorder carries this incredibly heavy emotional burden. Feelings of helplessness, intense guilt, shame, deep embarrassment.
Right.
And all of this can significantly increase the risk of self-harm. Sadly, studies have found really concerning rates of suicidal thoughts, like 12% in one study, suicide attempts around 11.5%, and even psychiatric hospitalizations in about 15% of individuals with the condition.
Those numbers are stark.
They really are.
Yeah.
It underscores that this isn't just a bad habit. It's a serious mental health issue with potentially devastating consequences.
Clearly. So what do we actually know about why someone develops this? What are the suspected causes?
Yeah, the exact causes, well, they're still not perfectly clear. But the general consensus is that it's likely a mix of things.
Like nature and nurture.
Pretty much a combination of genetic predispositions, psychological factors, and environmental influences. Stress is definitely a big factor.
Right.
And underlying mental health conditions like anxiety disorders or OCD seem to play a really significant role.
Right.
One Meiji theory is that skin picking kind of develops as a coping mechanism
Coping with what?
with difficult internal states. Turmoil, boredom, anxiety, stress, you name it. The idea is that maybe these individuals have a sort of impaired or dysregulated stress response system, and the act of picking itself might provide this immediate, though temporary, sense of relief or regulation. It's called automatic reinforcement.
Automatic reinforcement.
Yeah.
So the behavior itself becomes rewarding even though it's harmful long term.
Exactly. It's a tricky cycle. Now, what's happening in the brain neurobiologically, we're still figuring out. But there's some evidence suggesting a link to dopamine.
The reward chemical.
Right. We know certain drugs that massively boost dopamine, like cocaine and methamphetamine, can actually cause compulsive picking.
Oh, wow.
Sometimes with that weird sensation of bugs crawling on the skin, formication.
Right, I've heard of that.
So that's led to the hypothesis that maybe excoriation disorder involves some kind of dysfunction in the brain's dopamine reward system.
Interesting.
Yeah.
Any other neurological angles?
Yeah, some studies suggest people with the condition might have less motor inhibitory control.
Meaning they struggle to stop the action.
Basically, yeah. More difficulty stopping themselves once that urge kicks in. This seems related to a specific brain circuit, the frontostriatal circuit, and it actually shows some parallels to mechanisms seen in substance use disorders.
Huh. Similar brain patterns.
In some ways, potentially. But interestingly, they don't usually show differences in cognitive flexibility, the ability to switch tasks, or thinking patterns.
Okay, so strong urge, maybe less ability to hit the brakes, potentially involving dopamine. What about the genetic part you mentioned?
Right, the genetic component, evidence for that is definitely growing.
How so?
Well, there are some small studies pointing to possible links with specific genes. One is called ACE-PAP-P3.
ACE-P3?
Yeah. Animal studies found that mice missing this gene showed excessive grooming behaviors.
Like picking or pulling?
Kind of the mouse equivalent, yeah. Which prompted researchers to look at it in humans with trichotillomania hair pulling, and they did find a link there.
Yeah, maybe a link to skin picking, too.
It's suggestive, yeah. We need more specific research on excoriation disorder itself. But the connection is plausible, especially since trichotillomania and excoriation disorder often occur together and share features.
Right.
Plus, you see cases in identical twins, both twins developing the disorder, which strongly suggests some kind of hereditary factor is involved.
So likely a mix of genes and environment again.
Probably multiple genes interacting with psychological and environmental factors to create susceptibility. It's a complex picture.
It really sounds like it.
Hmm.
So if someone suspects they have this, how is it actually diagnosed? What are the formal criteria?
Okay, so the official diagnostic criteria are laid out in the DSM-5. That's the manual mental health professionals use.
Right.
To get a diagnosis, someone needs to show a few key things. First, recurrent skin picking that actually results in skin lesions or injuries.
Okay, actual damage.
Yes. Second, they have to have made repeated attempts to cut down or stop the picking.
So they're aware it's a problem and try to stop.
Usually, yes. Third, the picking causes significant distress emotionally or impairs their functioning in important areas, like socially, at work, or school.
Got it. Distress or impairment.
Exactly. Fourth, the picking can't be because of the effects of a substance, like drugs, or another medical condition causing itching.
Rules out other causes.
Right. And finally, it can't be better explained by symptoms of another mental disorder, like delusions and psychosis or body dysmorphic disorder focused only on appearance flaws.
That seems quite specific.
It is. And clinicians might also use a specific interview tool, the diagnostic interview for skin picking problems, the DISP.
PDSP.
Yeah, it helps systematically check if those DSM-5 criteria are met. Initial studies show it's pretty reliable at confirming the diagnosis.
That sounds useful. Are there other things doctors need to look for or rule out first?
Oh, absolutely. It's really crucial to rule out other medical conditions first.
Why is that?
Because lots of things can cause skin itching or irritation, which could naturally lead someone to scratch or pick.
Like what kind of things?
Well, skin conditions, obviously, like eczema, psoriasis,
Right.
but also systemic illnesses. Diabetes can cause itching, liver disease, Hodgkin's disease, other things. So a thorough medical workup is really important.
Make sure it's not primarily a skin issue or other illness.
Exactly. And beyond ruling things out, clinicians might use rating scales too.
Scales.
For what? To get a better sense of the impact, like the skin picking impact scale, the SPIS. That looks at how it affects someone socially, behaviorally, emotionally.
Okay.
And there's another one, the Milwaukee Inventory for the Dimensions of Adult Skin Picking, which helps understand the specific features of how someone picks.
Getting a detailed picture.
Precisely.
You've brought up trichotillomania hair pulling a few times. How similar are these conditions, really?
They are remarkably similar in many ways. Both are what we call body-focused repetitive behaviors, or BFRBs.
BFRBs.
They both involve these repetitive actions focused on the body. Crucially, unlike classic OCD, they're usually not driven by specific obsessions or intrusive thoughts beforehand.
Ah, okay. Less about a specific fear, more about the action itself.
Often, yes. They share similar triggers: stress, boredom, tension. Engaging in the behavior, picking or pulling, can sometimes help regulate how someone feels, their arousal level.
Interesting.
They also tend to start around the same age, often adolescence, and they co-occur quite frequently. If someone has one, their risk for the other is higher.
So definitely related.
Very much so. They share features like picking or pulling that can feel emotionally driven or even rewarding, and also this automatic type that can happen almost unconsciously, sometimes alongside things like ADHD.
Right. Any key differences?
One notable one is gender. Excoriation disorder seems significantly more common in females. Trichotillomania is a bit more evenly split, maybe slightly more females, but not as skewed.
Okay.
And interestingly, a study back in 2018 found that both conditions were more common in people with Tourette syndrome.
Huh. Another neurological link, potentially?
Potentially, yeah.
Yeah.
Shows the complex web of these conditions.
So they're clearly in the same family, these BFRBs. What about the connection back to OCD? You said it's on that spectrum now.
Right. And that's a really interesting point of discussion in the field. There are similarities with OCD.
Like the repetitive nature.
Exactly. The repetitive behaviors, and for some people with excoriation disorder, picking does seem to reduce anxiety temporarily, which looks a bit like how compulsions work in OCD.
Hmm.
However, there's also a strong argument put forward by researchers like Odlog and Grant that maybe excoriation disorder is actually more similar to a substance use disorder.
Addiction. That's a really different way of looking at it. Why?
Well, they point to a few things. First, that higher prevalence in females, we mentioned OCD, is more evenly distributed gender-wise.
Okay.
Also, for many, maybe even most people with skin picking disorder, the act itself can feel pleasurable or relieving. That's generally not the case with OCD compulsions, which are usually done just to reduce anxiety or prevent a feared outcome.
Right. OCD compulsions aren't typically enjoyable.
Exactly. Plus, treatments that work well for OCD, like SSRI medications and a specific therapy called exposure and response prevention.
ERP.
Yeah, ERP. They often don't work as consistently or robustly for excoriation disorder.
Huh. So different treatment responses suggest different mechanisms.
That's the argument. And as we said, the picking often isn't preceded by those specific obsessive thoughts or fears that characterize OCD.
So what are the similarities to addiction then?
Things like continuing the behavior despite knowing it's causing harm,
Yeah.
experiencing a strong urge or craving beforehand,
Mm.
and feeling that pleasure or relief afterwards. One study actually found that something like 79% of patients reported feeling pleasure when picking.
Wow, that high.
Yeah. So the idea is maybe there isn't just one single psychological driver. Maybe some cases do look more like OCD, while others function more like an addiction.
That makes a lot of sense, actually. It could explain why treatment is tricky if the underlying reason varies.
Precisely. It might not be a one-size-fits-all condition.
Given all that complexity, what are the approaches for treatment? What helps?
It's a bit frustrating because despite how common it seems to be, our knowledge about what treatments are most effective is still, well, a bit sparse. We need more research.
But there are options.
Oh, yes. The two main categories are pharmacological, using medications, and behavioral therapies.
Okay.
And also, things like group therapy or support groups can be really helpful. There's one called Obsessive Skin Pickers Anonymous, OSPA.
Like AA for skin picking?
Kind of, yeah. Peer support can be powerful, but a huge hurdle is just getting people to treatment in the first place.
Why is that so hard?
A lot of it is shame, embarrassment, people hide it. Also, lack of awareness. They might not know it's a recognized, treatable condition, or they might just believe nothing can help them.
That's tough.
It is. Studies show pretty low rates of treatment seeking. Maybe 45% have ever sought any kind of treatment, and only around 19% specifically saw a dermatologist. Another study found only about 30% sought help.
Wow. So many people struggling alone.
Yeah. It really highlights the need for more awareness and less stigma.
Absolutely. Okay, so let's talk about the treatment options for those who do seek help. Medications first. What gets tried?
Several classes of meds have been looked at. SSRIs are common, given the OCD link.
Right, like Prozac or Zoloft.
Those types, yeah. Also, opioid antagonists, anti-epileptic drugs, and something called glutamatergic agents.
Okay, a few categories.
Plus other things tested in smaller trials. People have tried various antipsychotics, anti-anxiety meds, other antidepressants. The results are pretty varied. Mixed success, you could say.
What about the SSRIs specifically, since it's on the OCD spectrum now?
You'd think they'd be a slam dunk, right? But the clinical evidence is surprisingly, not consistently strong.
Really?
Yeah, we don't have large gold standard double-blind trials showing clear benefit for excoriation disorder specifically. One big review, a meta-analysis, actually found that SSRIs and another drug, lamotrigine, weren't significantly better than placebo in the long run.
Huh. That's disappointing.
It is. However, some individual studies or case reports have suggested certain meds might help some people. Things like doxepin, clomipramine, naltrexone.
Naltrexone, that's an opioid antagonist, right?
Yes. Also pimozide, olanzapine. Small studies on fluoxetine, which is an SSRI, showed it might reduce some aspects of picking but didn't lead to full recovery. Another SSRI, citalopram, showed improvement on a general OCD scale, but not specifically on picking behavior itself in one small study.
So it's very hit or miss with the standard psych meds.
Seems that way, yeah. not the clear effectiveness seen in OCD for many people.
What about those other classes, the opioid antagonists?
Like naltrexone, not a ton of human studies for skin picking specifically, but there's interesting animal
Oh,
research.
yeah.
It seems to reduce self-chewing in dogs with a condition called acrylic dermatitis, which some see as an animal model for BFRBs.
Interesting parallel.
Yeah, and there are some positive case reports in humans. The thinking is maybe it affects that dopamine reward circuit, making the picking less rewarding.
Okay, plausible.
Yeah.
And glutamatergic agents, what are those?
N-acetylcysteine, or NAC, is the main one people talk about. It's basically an amino acid supplement.
NAC. I've heard of that for other things.
You might have. It's shown promise for other compulsive behaviors like addiction, even trichotillomania. And some small studies and case reports suggest NAC might help reduce skin picking too.
Okay, another avenue.
Yeah. Inositol, which is a kind of sugar alcohol, has also been looked at for both skin picking and hair pulling. And topiramate, an anti-epileptic drug, showed some benefit in a small study, but that was specifically in people with Prader-Willi syndrome, who have very high rates of picking.
So again, some possibilities, but nothing definitive across the board.
Exactly. The medication side is still very much an area needing more research to find out what works best and for whom.
Okay, so what about the psychological side, the therapies?
This is often considered the main line of treatment, really. Behavioral therapies are key.
Like CBT.
Cognitive behavioral therapy, yes. Also, variations like acceptance-enhanced behavior therapy and acceptance and commitment therapy, or ACT.
ACT.
But one specific approach that has a good amount of evidence is habit reversal training, HRT.
Habit reversal training. What does that involve?
Two main parts. First is awareness training, helping the person become really aware of when and where they pick, what triggers it, the earliest signs of the urge.
Okay, building self-awareness.
Crucial first step. The second part is competing response training.
Competing response.
Learning to do something else with your hands, something physically incompatible with picking whenever the urge strikes, or you catch yourself starting.
Like what?
Could be making a fist for a minute, playing with a fidget toy, sitting on your hands, something harmless that occupies the hands.
Got it. Replace the behavior.
Exactly. HRT has shown good results, especially for people without other major co-occurring psychological issues.
But it requires commitment, I imagine.
Oh, absolutely. And even then, remember that study I mentioned? It found less than half of people diagnosed even followed through with initial psych appointments, and less than a quarter got long-term results. It really highlights that this often needs a team approach.
Team approach.
Yeah, like your primary doctor, a dermatologist, a psychologist or therapist, maybe a psychiatrist for meds, working together.
Makes sense. Are there other behavioral tricks?
Yeah, other techniques are used too. Stimulus control is one.
Meaning?
Changing your environment to reduce triggers or opportunities, like wearing gloves, putting Band-Aids on fingers, dimming bathroom lights, removing magnifying mirrors.
Making it harder to pick.
Exactly. And different types of reinforcement strategies, like rewarding yourself for periods of not picking or for using those competing responses.
Okay.
These have shown some promise in small studies, but again, we need more large-scale evidence to be really sure how effective they are broadly.
And use tech solutions.
There's some early tentative evidence for devices that maybe give you feedback, like a vibration, if they detect you moving your hand to a common picking spot.
Huh. Like a smart bracelet or something.
Potentially, yeah. Still early days for that, though.
So it really sounds like therapy, especially something like HRT, possibly combined with medication for some, and maybe environmental changes. That's the main strategy.
That seems to be the most evidence-based approach currently, yes. But personalized, often involving trial and error.
Okay. What about the long-term outlook? If someone has this, what's the typical prognosis?
Well, without effective treatment, it can really interfere with life quite significantly.
So?
Mostly because of the shame and embarrassment. People might avoid social events, intimacy, job opportunities. Anything where their skin might be visible or they fear being found out, they spend a lot of energy concealing it.
That sounds exhausting.
It is, and untreated, this can be a really chronic condition. Studies suggest it can last for years, even decades, like 5 to 21 years was one estimate range.
Wow.
Many doctors really view it as a potentially permanent diagnosis, meaning it might always be there, with periods where it's more active or less active, often starting young and continuing into adulthood.
So early intervention seems really key.
Absolutely. The sooner someone gets help and learns coping strategies, the better the potential outcome.
Okay. You mentioned earlier the prevalence estimates are a bit fuzzy, ranging from 1.4% to maybe 5.4%.
Right. The exact numbers are hard to pin down. Different studies, different methods, you get different results.
Makes sense.
A U.S. phone survey found 1.4%. A community survey found 5.4%. College students around 4%. One study suggested like 63% of adults might do some picking, but only 5.4% serious picking, and maybe 2% of dermatology patients. So it's definitely out there.
And who's most at risk? What factors make it more likely?
Well, having other skin conditions can be a trigger. Acne is a big one. The picking might start with acne, but then continue long after the acne itself clears up.
Ah, the behavior takes on a life of its own.
Exactly. Also, things like keratosis pilaris, psoriasis, eczema, and stressful life events seem to be common triggers too.
Like what kind of events?
Marital problems, deaths in the family, unwanted pregnancies, major life stressors.
Okay. Age of onset.
Most commonly adolescence or later, between 30 and 45, but it can start earlier, even in kids under 10. Some research suggests traumatic childhood events might sometimes be an initiating factor.
And gender.
Statistically, it's definitely diagnosed more often in females.
Okay. And comorbidities. You mentioned it often comes with other things.
Very high rate of comorbidity, yeah. Especially mood and anxiety disorders.
Right.
One survey found rates like trichotillomania, 38%, substance use disorder, also 38%, major depression, anywhere from 31% up to 58%, anxiety disorders, 23% to 56%, OCD itself, maybe 16% to 68%, depending on the study, and body dysmorphic disorder, 26% to nearly 45%.
Wow, those are high overlaps.
Extremely high. It's much more common in psychiatric patient populations, too, and especially high in people with certain developmental disabilities, like Prader-Willi syndrome, you mentioned that before. Rates there can be like 85%.
Goodness.
So kids with developmental disabilities are generally at higher risk.
And is having it affect other parts of life.
Definitely linked to impairments, social, work, school, increased medical costs, mental health costs, financial burden. It's also associated with more difficulties in jobs and relationships.
And the substance use link.
Yeah, individuals with excoriation disorder are about twice as likely to have close relatives, first-degree relatives, with substance use disorders.
Suggesting shared underlying vulnerabilities, perhaps.
Possibly, yeah. And remember the identical twin cases. That points to a hereditary factor, too.
Right. Anything else from recent research?
One study from 2020 highlighted some demographics: over 75% female in their sample, over 45% unemployed, and over 60% single, divorced, or widowed.
What does that suggest?
Well, it doesn't prove cause and effect, but it suggests areas for future research, maybe looking into the interplay of gender, socioeconomic factors, and relationship status with the disorder.
Lots still to understand. What about the history? Has this always been sort of recognized?
It's interesting. The term neurotic excoriation was actually coined way back in 1875 by Erasmus Wilson.
1875, wow.
Yeah, and the first clear description in print is usually credited to a French dermatologist, Brock, in 1898. He described a girl picking at her acne uncontrollably.
So it's been known about for over a century.
Known about, yes, but really understood, not so much. It's remained surprisingly poorly understood for a long time. And like we said, a lot of what we know now still comes from online surveys, which isn't ideal.
Strange that it took so long to get more attention. Has media portrayal helped at all?
It probably has raised some awareness. It was featured on that TV show Obsessed about anxiety disorders.
Okay.
And it was part of the character's struggle in the movie Black Swan, linked to her anxiety and perfectionism.
Right.
But probably the biggest recent moment for public awareness was Miss Alaska 2021, Emma Broyles.
Oh, yeah. What happened?
During the Miss America competition, she spoke very openly about her own struggles with dermatillomania, with skin picking.
Wow. On that stage.
Yeah. And then she went on to be crowned Miss America 2022. Her willingness to be so candid about it, I think, really helped bring it out of the shadows for a lot of people and reduce some of that stigma.
That's fantastic.
Yeah.
A really powerful way to use that platform.
Definitely.
So, okay, pulling this all together,
Mm-hmm.
it's crystal clear this is way, way more than just a bad habit.
Absolutely. It's a recognized complex mental health condition. It has real significant psychological and physical impacts.
Right.
It seems to involve this intricate mix of potential causes, genes, brain function, environment, psychology, and it shows up in varied ways.
And treatment is possible, though challenging.
Exactly. There are challenges for sure, and we need more research. But various therapies, sometimes meds, offer real hope for managing it and improving quality of life.
And just understanding it better, destigmatizing it, seems so incredibly important. Encouraging people not to feel ashamed to seek help.
Couldn't agree more. That's crucial.
So, as we wrap up this deep dive, maybe here's a final thought for you, the listener, to mull over. We talked a lot about the links to stress, anxiety, underlying mental health stuff.
Mm-hmm.
It makes you wonder, doesn't it, about the more subtle ways these kinds of body-focused coping behaviors might show up in society generally, even in people who wouldn't meet the full criteria for a disorder.
Yeah, like where's the line?
Right. Maybe just something to reflect on that whole spectrum of behavior. How might stress or anxiety be manifesting physically in these repetitive ways, maybe more often than we realize or talk about?
That's a really interesting point, thinking about it as a continuum.
Well, thank you for diving deep into this with me today. It's been really informative and, frankly, quite eye-opening.
My pleasure. It's an important topic to understand better.